I think we'll get started. I'm just really excited to be here today with Margot again. This is the third time we've had Margot back to do a webinar for us and for our clients. It has been really well received every time. Margot is a Medicare expert. She is really wonderful educator, really does a great job of talking about all the complexities of Medicare and breaking it down for us. And so really excited to have her back here. As a little fun fact, Margot and I spent a weekend sleeping in adjoining or adjacent dorm rooms at UC Santa Cruz at one of the conferences recently. So she's out there speaking at conferences and sharing all of her expertise with other financial planners and their clients. So Margot, we're really excited to have you here today. If you want to go ahead and share your screen, I will get us set up. And I'll turn it over to you to introduce yourself.
Awesome. Thank you, Lauren. And thank you all for showing up today. Hopefully you have a full cup of coffee and a notepad. You're going to need it. I'll cover a ton of ins and outs of Medicare. I'll sprinkle in some ACA advice for anyone who's under 65, maybe looking at early retirement as they are approaching their 65th birthday or maybe 60th birthday. What does that ACA market look like for you? How does COBRA play into the equation? But essentially, I'll go over everything with regards to Medicare first, but a little bit about myself and my agency here. We are a third generation family owned and operated health insurance agency. All of our services are free. Shoot me an email anytime. We will work with you. The only individuals, unfortunately, that we cannot service and provide high-level guidance and advice to are federal retirees. But do not fear, I have a great resource and contact for you if you need it. So if you are a federal retiree, shoot Lauren or myself an email and I'll put you in contact with her. For everybody else, I can typically help. My team of almost 30 employees are here to assist and provide high-level holistic health planning. So if you and your spouse are looking at retirement and maybe one of you needs Medicare, the other is looking at COBRA and ACA, you are a perfect client for us to come in, get into the weeds, and help you decipher what's required, what's not, and keep your cost as low as possible. Again, there's no charge for me. How my agency works, I always get this question, so I like to bring it to light right out of the gate. We go and get appointed with all of the national and major insurance carriers across the country. And if you need Kaiser in Colorado, Kaiser in California, AARP, Anthem, Blue Cross of California, Highmark, if you're out in Pennsylvania or West Virginia, we have all of these contracts under my agency and my team is all salaried. So whether you go Kaiser or UHC or Humana or Aetna or Cigna, all of these carriers, they will pay my agency a commission if you do opt for coverage. But again, my team is fully removed from that commission aspect. They're getting a nice salary, so they're giving you advice regardless if it's, hey, stay on your group for a little bit longer. You're not ready for Medicare. Your group is really attractive compared to your IRMA and your Medicare costs. Or stay on COBRA for 18 months and then come talk to us about the ACA market at that time. We get a lot of clients who are in those boats and in that camp, and we give a lot of free advice that doesn't bring in any money to our agency. So again, at the end of the day, we are working for you. We are not working for the carriers, and we're trying to give you just this unbiased, neutral advice and be there in the pre-enrollment kind of strategy, creating your timeline space, and then hold your hand through the actual Medicare A and B enrollment. And then on the back end, be there if you need a new card or there's a billing discrepancy, just provide support both at kind of every level of this engagement. Again, we are in all 50 states for Medicare and ACA. So again, feel free to lean on us, but let's get jumped into the nitty gritty here. So I'm going to cover three main parts on this presentation. Who is eligible for Medicare will be the first kind of segment. And then we're going to look at what is Medicare? What's Medicare supplement? How does Medigap play into this equation? How does Part D and Part C Medicare Advantage play into the original Medicare picture? So we're going to define a lot of terms and look at pros and cons. What's kind of the best or optimal pathway, and how does that impact you long term? And then lastly, we're going to look at upcoming regulation shifts. How does the 2022 Inflation Reduction Act impact you this year and next year? What is IRMA? If you're new to these webinars and seminars that I put on, IRMA will be a fun term to learn. And if you're a high earner, it should be on your radar. Medicare is not free. And then lastly, we'll look at those ACA shifts for anyone who is kind of on the cusp of early retirement, needing that gap or bridge coverage to get to 65. Okay, so the general rule here is that as you approach your 65th birthday, something has to be done. Most people need to sign up for Medicare upon turning age 65. Or face lifelong penalties and potential gaps in your health insurance. So the general rule here is you need to elect or enroll in Medicare Part A and Part B in your 3-month window before you turn 65. My birthday's June 29th. You know, give me some love if your birthday's June 29th too, but my birthday is June 29th. So if I were to start my Medicare, if I was 64 and a half and I'm thinking I want to go on Medicare, I'm going to start that process in March. So the first week or the third week in March, I'm going on ssa.gov and I'm signing up for Medicare through Social Security's site. And my Medicare will start June 1st because I was born in June. Okay, if you were born on June 1st, you actually get a month early. A month of early eligibility. You would have May 1st as your eligibility. So most people will sign up in that first 3-month window unless you or your spouse have access to large employer coverage. So I'll use my example here. I'm turning 65 June 29th in 2026. Not really, but soon, right? And my agency has 30 employees. I'm a large employer. So if I were turning 65, I could either delay Medicare or opt to move into Medicare. So that general rule, you have to sign up for Medicare at age 65 to avoid the penalties and gaps, unless you are working with a large employer, which means 20 or more full or part-time employees. Then you and or your spouse can continue on that large employer's group health benefit. Maybe there's an HSA component that's really attractive, or you have kids on the plan too. You can continue on that large group plan and delay Medicare. You do not have to sign up for Part A or the premium Part B portion. You can delay it until you or your spouse are ready to come off that large group benefit, that plan, whether it's retirement or maybe they shift from a really wide network with Blue Cross and they squeeze it down to Kaiser and you're unhappy, you don't want to go to Kaiser doctors. You can move off into Medicare whenever you feel it's appropriate. It doesn't have to just be at retirement. So you create this special election window any month. At 65 and a half or 70, you can choose to come off that large employer's group health plan and create a special enrollment period to pick up Medicare A, B, supplement, drug plan, Medigap, Medicare Advantage. You can pick it all up when you do create that special election window at a later date. Okay, so the size of the employer is the key factor here. If there's fewer than 20 employees, most small groups require Medicare enrollment because Medicare is the required primary payer. All right, most small groups require you to enroll in Medicare Part A and Part B upon turning 65. There's a handful of carriers and options that do not require Medicare to be primary, even though it's a small group. Okay, that's not the norm though. Most people need to sign up for Medicare upon turning 65. If you're on ACA, you're uninsured, you're retired, you're on small group, you're picking up Medicare at 65. Okay, if you're on COBRA, you're picking up Medicare at 65. If you work past 65 with a large employer, it's optional. We're punting it for another year or two under most circumstances until you're ready to retire. Okay, also note that COBRA is not creditable coverage. It's not active employment. So even though, and this is where a lot of clients get in trouble, is their employer will say, hey, you were an awesome employee. We are going to subsidize the full COBRA cost for 9 months or 12 months or 18 months. We'll cover the $3,000 premium a year because you're awesome and we want to, you know, take care of you. That's great. It doesn't mean you can delay Medicare too. Okay, you still have to sign up for Medicare quickly because COBRA is not primary coverage. COBRA would float secondary as soon as it's triggered, and then you have Medicare as the primary payer. If you keep, and I've seen this happen time after time, so I harp on it in every presentation, many clients will keep that free COBRA, that subsidized COBRA through their employer, and never sign up for Medicare, and now they're in the hospital for a week and they need a outpatient surgery and they don't have a primary payer. Bills are being declined, denied because they don't have Medicare primary, because they thought, hey, I have free coverage. Why would I sign up for Medicare with IRMA? So be alarmed. Also, if you are delaying Medicare after age 65 because you have awesome large employer group coverage, or you want to keep a spouse and younger kids on that, a large employer plan, and you want to max out an HSA, a health savings account that's linked to your high deductible health plan, you need to delay both A and B, the free Medicare Part A and the Part B. Okay, you can't pick up the free Part A and still max out that HSA. So you delay both A and B, you continue on your large group plan, continue maxing out the HSA, everything's great. And now when you are ready to retire, let's say January 1st, and you reach out to me, you say, hey, Team Steinlage, I'm ready to retire. What do I need to do to get my Medicare A and B in force for this January 1st retirement transition off my group and over to Medicare? I'm going to say, hey, we'll submit your Medicare paperwork in October, 90 days out from the desired retirement shift and transition. We'll submit in October. Medicare will place your Part A hospital benefit retroactively into force 6 months prior to the month we submit paperwork. So if we submit in October, that means you're getting a April 1st Part A effective date. Your Part B, the premium portion, will go in effect January 1st. And I mention this because the year you retire, or maybe the year prior, depending on the timing here, we have to be conscious of when we stop the HSA contributions. You can't max out an HSA when you have that 6-month look back for Part A coming into the picture. So here, again, just some planning can help you avoid just headache and extra work. But here, in theory, if you know you're going to retire in the coming year, we need to know that retirement date so we can reach out to you in advance and say, hey, this is the last month that you can contribute into your HSA. Prorate the allowed amount this year or last year based on this 6-month look back. Okay. If you've over contributed, we can remove excess contributions for the tax filing year. But once you file, it's kind of set in stone unless you want to pay big bucks to amend it, which I don't know if that's worth it with CPA costs these days. So just be conscious, again, a little bit of pre-planning is key here. So watch out for HSAs, watch out for COBRA. Those are the two alarms that are usually going off for many clients. Also, if you elect Social Security at like age 70 and you're still working with a large employer, be aware that as soon as you collect Social Security, your Part A will go retro 6 months. Social Security benefits and Part A are combined. You can delay B, but as soon as you enroll in Social Security, you have to take Part A, the free portion. Okay, let me get some of my turmeric tea. More on these HSAs. So once you are HSA, you have 20 grand in your HSA. It can be used for any medically qualified expense. The only thing that's not medically qualified in Medicare is your Medigap premium. You can't use HSA contributions. Also, ACA premiums are not medically qualified. But COBRA, dental, drug plans, Advantage plan costs, drug plan copays, all of those are going to be qualified expenses. All right, moving along. I think, Lauren, we had a question. Let me see my screen here. We have a chat. Oh, it's just you all chatting. Okay, so what is Medicare? This is that second part of the conversation or the slide here, or the presentation. Medicare in a nutshell, when you get your red, white, and blue card, some of you may grumble because the realization that you're 65 has hit. Others are excited because it'll save you a ton of money compared to your small business plan or ever rising employer costs. But Medicare is not free. In general, there are premiums that you pay, and they can be quite high if you are deemed a high earning individual, which means anyone who is making above 106,000 is a single tax filer and modified AGI, or 212,000 in joint filing status and modified AGI. So if you are making above those figures, awesome, but Medicare is going to be quite a bit more expensive for you. And that threshold, that modified AGI level or bracket is called IRMA, income related monthly adjusted amount. And it's a surcharge on your Medicare Part B and Part D premiums for any high earner. And I'll talk about IRMA in detail, but I want you to be aware of it in the early conversations here because it will impact your initial decision to move into Medicare. Medicare is not free. It's not $185 for most people that we tend to work with. It's actually quite expensive if you plan to work beyond age 65 and can't appeal this IRMA. So in the early stages of planning, we need to know what your IRMA will be so that we can give you wise advice. If you're going to pay close to $1,000 a month per person to move into Medicare versus your $400 group plan with an HSA, I need to know that so I can say, don't take Medicare, delay, stay on the group, watch out for the HSA and the Part A. Okay, so our intake form that we get and that Lauren knows all about is very aggressive. My team needs to know your modified AGI, and we'll bring in Yeski Buey for a lot of that information because we don't have it. You may not even have it. We like to again bring in the whole team, the CPAs, your advisor, ourselves, so we can strategize here and give accurate information. There is no blanket advice here. But again, everybody will sign up for Medicare A and B at some point down the road. It's just a matter of when. But when you are ready to come off that large group plan and retire, or you're retired already turning 65 or on ACA or small group, or uninsured and you're turning 65, you have to sign up for A and B. What are you getting with just original Medicare, the red, white, and blue card? So most of us pay zero for the Part A benefit. We have the 40 quarters between, me and my husband, we have 40 quarters easily. So don't be alarmed if you had a stay-at-home parent or somebody who, was a caregiver and never really got paid in the system. You can piggyback on a spouse who has the 40 quarters and get this Part A benefit for free. Part B is $185 per month. And every year, the last 5 years, the average increase is 5% per year. That may swing, 10, 12%, but the average has been 5%. Next year, it's going to be about 200, 210 is what the experts are anticipating. So again, that's a base premium, roughly $185 this year, $200 next year, plus any IRMA if you are a high earner. Okay. Now you have your red, white, and blue card, and you walk into the hospital. You have COVID or the flu, or your pancreas is out of whack. You're in the hospital for 2 or 3 days. With just original Medicare, you have a $1,600 deductible exposure. And that resets per 60-day occurrence. So if you go in 6 months later, you go in January and then in June, you have that $1,600 exposure again. Part B, the medical portion, will cover ER visits, outpatient surgeries, doctor visits, your preventative colonoscopy. It's going to cover, remember to schedule those. It will cover a lot of things for you. It's kind of the umbrella package here, but in a nutshell there, you have a very small deductible exposure. It's $257 per year. And most of those preventative services don't even touch the deductible. They're covered pro bono, but here you have the $257 and then 80% coverage by Medicare. Your exposure here for medical claims is 20% with no cap or ceiling. So these are the gaps of original Medicare. So Medicare is not free. It can be quite expensive if you're a high earner, and it doesn't cover everything. You'll see here, there's no drug coverage baked into that red, white, and blue card. There's no dental or vision or hearing. So how do we fill the gaps of original Medicare? This is where all of the noise in the market is happening. You have Medicare supplements, Part D, Medicare Advantage plans, Joe Namath on the TV, and all the old ex-football players who are just trying to make a buck. Can't blame them, but they do not have Medicare Advantage plans. They definitely go the supplemental route. I actually, this is funny, but I had a retired NFL player who actually played with O.J. Simpson call this morning. And the NFL subsidizes their supplement package, Medicare supplement plan. So kind of fun to find out, but they do not have Medicare Advantage plans. Most of them stick with the supplement. So here there's a lot of noise. You're going to receive a ton of solicitations and phone calls as you approach your 65th birthday. And be ready. Be on the do not call list. Many of you are, but unfortunately that nobody's respecting it these days. You're going to get blasted with the solicitation. So be ready. But essentially, you have to make this decision when you turn 65 or you're ready to come off that large group plan. A decision has to be made. Are you going with a supplement plan and a drug plan? Or are you going with that Medicare Advantage Part C option? And some of you may have a third option with like a retiree plan. And we do a lot of pros and cons and reviews of retiree packages too. I will say most retiree packages don't beat the private market. It just seems like they're getting watered down. 10 years ago, most retirees had maybe a supplement option available. In the last like 2 to 3 years, most of those retiree plans have turned into a Medicare Advantage plan. And again, there's pros and cons and there's premiums on those Advantage plans. So most of the time when we actually get into the details of the retiree package, it's not as attractive as what these private options are allowing. 9 out of 10 times the retiree option doesn't beat these private options, but sometimes they do. So we like to review them. So here, most of my clients, because I work with a lot of financial advisors all over the country, are leaning heavy towards this Medicare supplement product and standalone drug plan pathway. So most of you on here will lean and kind of opt for this level of coverage. With that being said, I'm going to go back a screen. The national average, there's about 55% of the population that go Medicare Advantage. 45% will opt for the supplement and drug plan. And that Advantage number grows every year. They're getting more and more competitive. In the past decade, they've become more and more competitive. Networks are getting bigger. So these Advantage plans have a place and market. But again, if you can afford the supplement, it's going to be the path to go. And I will also say, I think there's going to be a plateau on these Medicare Advantage numbers because of recent regulation with the Inflation Reduction Act. We're just seeing United Healthcare, Elevance, which is like the Anthem, Blue Cross carriers. We're seeing Aetna, Humana, all of their stock has tanked this year because of their new exposure under the Inflation Reduction Act and just changing market. We've seen PPOs disappear for 2026, massive plan exits on the Medicare Advantage side. HMOs are getting limited, 5, 6, 7 grand of free dental. Now it's gone. All of these perks and bells and whistles that these Advantage plans use to lure in enrollment and entice people to go that route are getting axed because these Advantage plans are hemorrhaging money right now. So if you're somebody who's on the fence of supplement versus Advantage, and I'll show you why, the supplement pathway for at least your first year into Medicare should be the route. And then we can easily move Advantage as the market kind of settles in the next year to 2 years, as it feels out and just ripples back from these regulations that are unfolding. So just some market inside scoop. Again, it's my opinion, but if you can afford this supplement, you'll see why. It's going to give you the most flexible coverage and unlimited coverage in the sense of access to doctors. So here, if a client is like, Margot, I have kids out of state, I travel a ton, I want fluid movement, I don't want a carrier kind of dictating my care, then I'm going to say grab the supplement and drug plan pathway. Medicare will be your primary payer. You can continue seeking care at any provider nationally that accepts Medicare. So if you want to go Mayo Clinic, Johns Hopkins, any Mercy care across the country, you have access to any of these big hospital systems. Emory, I'm an East Coaster over here. So you have access. If you're skiing in Utah, lucky you, and you break a leg, you have coverage without having to fret about out-of-network care and cost. These supplement plans come in and pick up the residual after Medicare pays. So just how this works in real life is you go to the doctor, the Medicare provider, Medicare bills, or the doctor bills Medicare, Medicare pays its 80% roughly, and submits the deductible and the residual 20% to your supplement carrier. And your supplement G or N will pick up those costs, no questions asked. So you never get this massive bill saying you owe all these copays for your 7-day stay. It's this nice packaged, here's your Medicare summary notice of what everybody paid. So if you want headache-free coverage, this is going to be the pathway. The supplement G is the best level of care, that coverage that you can get. It covers all of the gaps in original Medicare, except for that Part B medical deductible, the $257, and then Medicare and your supplement pays 100% after that. N is a little bit lower in benefit level. You'll have that deductible and $20 copay and $50 copays, plus Part B excess charges. Where you don't have coverage in this model is if you go to a non-Medicare approved provider. They have opted out of billing Medicare at all. So about 50% of mental health experts and psychiatrists and psychologists do not take or participate in Medicare. So heads up there as you approach Medicare. Those are the most prevalent providers that are not accepting Medicare. Some of the PCP, like the VIP MD, my parents use VIP MD, they pay $2,500 or $3,000 a year to have their doctor's cell phone at their beck and call. They really do. It's actually quite nice for my grandmother, but they can still bill Medicare because the provider opts into Medicare. They're just charging this VIP MD this access to his personal line. And he can, make extra money that way and still bill Medicare and not have to gripe about Medicare's reimbursement schedule to him. So here, the key is to find a PCP and your specialist. Make sure they take Medicare. After that, you're going to have great coverage. Also a pro tip, if you are somebody who doesn't go to the doctor routinely for their annual checkup, if you're like 64 and a half, go have that intro or annual visit before you turn 65. Because a lot of these doctors will say, hey, we're not taking any new Medicare patient, and you are no longer a active patient if you've gone 1 or 2 or 5 years without seeing that provider. So they may, in your eyes, be your provider, but if you haven't seen them in 2 or 3 years, you're no longer an active patient, and you turn 65, you walk in the door with original Medicare, they opt into original Medicare, but they say, hey, we are already at max capacity. Medicare doesn't cover our bills. We only take 70% new patients on Medicare. The rest we're leaving to employer coverage. So don't get pinched there. Set up that relationship, rekindle the relationship with your provider. So when you turn 65, you are already a patient. And again, you don't have much exposure once you do have the Medicare in force.
Margot, if I can jump in, we have 2 quick questions on the supplement letters.
Yeah.
One on just maybe a bit more context on what are the letters and what do those mean? And then a specific question from someone who was grandfathered in on supplemental plan J, and whether it makes sense to stay on that or to revisit and move to a new one.
Okay. Oh, Jay, you are a rare bird out there. I love it. I'm going to guess you're probably in your 80s. Okay, so here a couple things. So J was grandfathered, F was grandfathered. In California, we can move down to a G or an N for better rates because of the California birthday rule. Many states have birthday rules where you can move and kind of modify your supplement coverage with no health questions. So you can rate shop, you can check to see who's giving you the most bang for your buck. J is unique. I've only had one other client with a plan J, and we opted to keep her and her husband with plan J because the drug benefit. I guess I have another question. Do you have a standalone drug plan? If you do, great. We can move and modify and find cheaper coverage for you. If you never elected to get a standalone drug plan, your J built-in drug coverage is not creditable in the eyes of Medicare. So you're going to get hit with a late enrollment penalty if you do drop your J and go plan G or N for cheaper and just as good of coverage. You would get a standalone drug plan, but again, because you're on J and it's not creditable with that baked in drug benefit, you're going to see a penalty. So I'd have to weigh kind of pros and cons there. I need more information. Email me. G, again, just kind of answering that question, Lauren, G covers all of the gaps in Medicare except for the $257 deductible. N is just like G, except it's about $20 or $30 cheaper per month. You have the $257 annual medical deductible. And then N will pick up the 20% gap, that $1,600 deductible. What N lacks is you have the $20 copays anytime you see a provider, the $50 ER copay. And if you go to a Medicare provider who opts into Medicare, okay, they sign up, they're contractually obligated to accept the billable terms of Medicare. If they are non-assigned, they legally in most states can bill 15% above Medicare's base reimbursement schedule. So I'll give you just a very basic example of how that would play out. If you are getting an MRI with a non-Medicare or with a Medicare provider, but who's non-assigned, Medicare will reimburse that provider $1,000, the base scheduled rate, Medicare's rate, and the provider can balance bill. Balance bill, I say that loosely. They can send you a claim or a bill for 15% of that charge. So in this example, 15% of $1,000 is $150. So you owe $150, 15%. Medicare will reimburse $1,000. the doctor gets, you know, 1,100 essentially, close to 1,100. So in the DMV area, we see a few doctors. If you're in DC, I'm not sure how many are in DC, but Foxhall is a perfect example. They're like a big, I think they have dermatology, urology, OBGYN, and PCP, maybe one other specialist. But you can go seek care with Original Medicare, but if you have a Plan N, you're likely receiving some type of extra bill or invoice for excess charges. Your Supplement N doesn't cover those excess charges. Your G, your J, and your F cover those excess charges. They will reimburse and indemnify you for any excess charges. Okay, most providers nationally accept both. They opt into Medicare and they accept assignment. So you don't want to like fear mongle here, but it's just an extra question of, do you take Medicare and are you assigned, like a Medicare assigned provider? Do you excess charge? Okay, and unfortunately, a lot of staff don't know the difference between a supplement and an Advantage plan. And if you just walk in saying, I have AARP United Healthcare, I have the best coverage, they are going to think you have a Medicare Advantage plan every single time. So make sure when you have this level of coverage, what you need to say is, I have Original Medicare. Flop your red, white, and blue card down, and it's like you have a VIP card. They love seeing the red, white, and blue card versus the Medicare Advantage cards. So just asking these questions, we can always do a check. Medicare.gov Physician Finder is a great tool that we use to make sure that the supplement or the Original Medicare is being accepted. Standalone drug plans, this is a wild ride. Every year we'll review our current clients and their drug coverage, because this is such a volatile specific market in the prescription costs. Here you will see swings. You know, your $20 Silver Script Smart plan is now $40, and there's talk, they haven't released their full rates yet in all markets, but some markets it's going to be about $100 for that same coverage. So there's a lot of volatility. Do a drug review. We may be able to save you a couple of $100 on a supplement to supplement change, or a drug plan to drug plan change. The best is when we're like, we're saving you $4,000 for identical coverage. That's always a lot of fun. But sometimes we can't. It just all is dependent on the market, your specific medications, your pharmacy. Are you doing mail order? Are you taking brand versus generic? We want, again, we're aggressive on our intake form. We want all of that info so we can give you detailed information in this setup. So the negative here is it's expensive. If you want to add dental and vision, everything's kind of piecemealed a la carte. And if you're a high earner, again, it's not free. It's $500, $600, $700, or $1,000 a month for this whole package if you're in the highest IRMA bracket. If you're not seeing any IRMA, you fall under 212,000 as a joint or 106 as a single filer, then this will be about $300 or $400 a month for the package. Okay, Medicare Advantage. I always explain Medicare Advantage, all the good and the bad, because you're going to have neighbors or family in Kentucky who has a zero premium, and I don't pay anything for my coverage, and you're over here paying $1,000 a month. It's good to know that there is a whole nother market that people can tap to keep their costs low. On the flip side, they don't have total access to care. They don't have the ability to go to any doctor that takes Medicare. As soon as you sign up for these zero premium HMO or PPO Medicare Advantage plans, also known as Part C, it combines your Medicare A, your Medicare B benefit design with drug, with dental, with vision. It's like one combined packaged coordinated care. You show your AARP card, you flop it down on the counter. You're showing your Humana HMO card, you're showing your Aetna PPO, your Kaiser HMO. They are the gatekeeper, the dictator. They determine the who, what, when, where, why. you may or may not have to appeal a service. You need pre-authorizations. So everything has kind of the if and then question. If I need surgery, then what is my carrier going to say? Your doctor doesn't manage your care, your insurance carrier does. And some people could care less if that's the case. To be honest, it's kind of how our employer plans are. We're in an HMO or a PPO, and my Anthem, point of service plan is very flexible. I'm grateful for an employer plan, but I still have to play by the rules of Anthem. So it's not like this is some foreign concept, but the Advantage plans are much more limited in access to care than your employer plans generally are. These plans are very similar to ACA networks where doctors come, doctors go. Right now, there's about 20 big hospital groups that are fighting and actively negotiating with United Healthcare, Anthem, Aetna on network status. So as hospitals consolidate, these hospitals have more weight and can say, hey, United Healthcare, hey, carrier, don't bully me. I want more money for my surgeries and my doctor visits and my procedures. And next thing you know, your doctors get dropped mid-year because they couldn't come to an agreement with the carrier. And now, unfortunately, the consumer is left holding the bag. So here, there's been one instance where CMS came in and overrode a decision and said, hey, anyone in this area, these zip codes that are affected by this network hospital drop, you have a special window to move to a different carrier. But outside of that one instance, I think it was in the Northeast, I'd have to go back to the article, but it was kind of setting precedent for what's to come as these Advantage plans are getting beat up by the hospital groups. There may be some wiggle room to move if a huge group gets dropped and many patients are impacted. But right now, if that happens mid-year, this is a negative to going this route. You can't change your Advantage plan until an open or annual enrollment period, which would be in the fall and in January. Okay, so again, I want to go over these pros and cons. These Advantage plans are super cheap, zero premium. In California, you could have like a $1,900 medical max out of pocket plus your $2,000 drug cap. That's pretty affordable. It's not $500 a month, $6,000 a year in cost. And I never leave my home, so I don't need a wide network of providers, and I'm okay with not having the most well-renowned provider access. So some people, this is a market. Others who want the flexibility will go supplemental. But the negatives here are the network drops, the ability to lose a doctor like that, appeals. You read a lot about United Healthcare because they are one of the largest providers who will deny claims. 90% of appeals are approved on the second time. But again, who wants to do that? Who wants to be an advocate for your care when you're, needing a knee replacement? So buyer, be aware, know what you're getting into. And I would say the biggest negative here, which is the case in California and Virginia and 98% of the states, is if you go Medicare Advantage because you say, hey, I'm super healthy, I'm retiring, my income's not flowing, I want a zero premium pathway, I want to go Advantage. And later at age 80, when you realize oh my gosh, there's no skilled care that's in my network, there's one primary care doctor or 15 doctors, my doctor that I want is not in network, or I'm sick of these pre-authorizations. As soon as you want to drop your Advantage plan and move over to that supplemental pathway, you have to answer health questions. So when you are turning 65 or you are new to Medicare because you're coming off that group plan, there's this beautiful window of free choice. You can go with a supplement or an Advantage plan. There's no health questions. There's no restrictions. Outside of that new to Medicare or coming off the group plan window, if you go Advantage and then 3 years later you want to go supplement because you realize that's not planned for me. The supplements are going to say, okay, how's your health? Most people will say, great. But from the eyes of the insurance carrier, you have AFib, you're on tramadol, you need PT because you have carpal tunnel. You are a high health risk. And now you're denied access to the supplement market, and you're left with that Medicare Advantage market. And you can move carrier to carrier within the Advantage product, but you're locked out of that awesome supplement free choice option. So just, again, make sure you're doing your education, you know what you're getting, you know what you're signing up for, because your initial decision on one of these routes or pathways can be detrimental long-term if you do want that open access and freedom when you are starting to use care. All right, more on that Inflation Reduction Act. So and let me just take a step back, no matter what decision you guys choose, this $185 per month, or 5%, 10%, 3 years down the road, whatever it's set at every year or every month, you are responsible for regardless of your decision, plus any IRMA if we can't appeal it. So that's kind of fixed cost or standard cost that you should anticipate every year, regardless of the supplement or the drug plan or the Advantage plan you choose.
And Margot, can I jump in? We've got a couple questions. I think some of them are coming up in your slides, but one on that specific, the Medicare Part B premium there, and a slide you shared earlier. Is it possible to pay, which parts of Medicare premiums can you pay through an HSA? And how does that shift when you start collecting Social Security? Because usually they will withhold premiums from your benefit.
Great question. So the drug, or the Part A, if you do have a premium, again, most don't. Part B and IRMA are all medically qualified expenses under your HSA. When you start collecting Social Security, this Part B will automatically come out of your Social Security check. You can't use the HSA at that point. I don't think I've ever said that out loud. So whoever's asking that question, I'm going to add that to every presentation because that's a great question. But use the HSA early on, but it will come out of your Social Security check at a later date when you do start collecting. Or if you collect day one, you don't get access to your Social Security. And then the supplement, we can never set up for a Social Security grab, and it's not a HSA qualified. So usually we're doing a EFT auto pay, or if you're old school, you want the quarterly or annual bill, we can set that up too. Drug plan, we can do out of an HSA, we can do direct bill, we can do EFT, or out of your Social Security check, but it's voluntary for the Social Security once you do start collecting. Any other questions?
There are a couple more. Maybe I'll just ask them now because some of them are in some of the earlier pieces. The first one is just when you were talking about hit age 65, whether you have a large group plan or making that decision, if you stay on the large group plan and you lose coverage, let's say you get let go, what's the grace period to then sign up for A and B?
Yeah, so it's tricky. So you legally have 8 months to enroll in Medicare A and B with no penalty. If you go a full year, you're going to see a 10% Part B penalty, and you're limited to enrolling in that general January through end of March enrollment period. So don't delay more than 8 months, number one, for the penalty aspect. Number two, you have to look at Medicare secondary payer rules. Will Medicare, or will the COBRA that you get pushed to pay as primary? And 98% of COBRAs that we have seen and followed will require Medicare to be the primary payer right out of the gate. So the 8-month window doesn't impact who's paying. The 8-month window impacts who's getting penalized with the Part B enrollment, but not the actual gap in coverage on primary or secondary payer status. So this is where we have seen clients say, oh, shoot, I thought I could sign up in that 8-month window. And then all of a sudden claims start stacking up and nobody's paying because everyone's pointing fingers saying, hey, you should have Medicare. Medicare needs to be the primary payer, not COBRA. So again, the contract terms of the COBRA and the carrier should be able to give us that information. most of the time you want to get over to Medicare sooner rather than later to avoid that gap, not necessarily the penalties.
Great, thank you. And then two quick related questions just on approaching that shift to Medicare. You were mentioning that you need to be active with your primary care physician in case they don't take new Medicare patients and you would be considered a new patient because you're inactive. Someone's asking a question saying, I see all my providers regularly just don't have a primary care physician. So do I specifically need a recent visit with a PCP before I shift onto Medicare?
No, not to access other specialists that you already have great relationships with. The only reason I would say find a PCP before you go on Medicare is, depending on where you live, it can be hard to find a PCP who is taking on new Medicare patients. So if you don't have that relationship created, you could be on a wild goose chase, again, depending on where you live, to find a good doctor that has referrals and recommendations coming. Because they may say, sorry, we're not taking new patients. You're on Medicare already, new Medicare patients. So I would just kind of sniff around. You can make some phone calls and see if they're taking new Medicare patients. And then if they say yes, then there's no rush to create the relationship before you go on Medicare.
And is that where the Find a Physician Medicare.gov is helpful too?
Yeah, you can look on there. It'll say, it's been a while since I've used it. My team is the one who's doing it most of the time, but I want to say if a doctor doesn't show up, they don't take Medicare. They're not opting in. If they show up and there's a question mark, that is indicating that they take Medicare, they opt in, but they're not Medicare assigned. They can do that excess charge if you have the plan in. So just a heads up there, but yeah, you can go on Medicare.gov, you can physician finder, you can do like a radius search of your zip code and pull up specific doctors. And then I'd just make sure, because again, everything online is questionable, especially on those advantage markets and the ACA networks. Always fact check with the actual provider. So yeah, my 2 cents.
Yeah, for everyone, I just pasted the link into the chat of that Medicare Find a Physician. And Margot, you're right. I see the question mark there on a couple of them in the San Francisco area. I was just doing a quick search. So one more quick question. I know we only have a few minutes left, but I figure we'll get this quick question and then I know you have some updates to share.
Gotta do at least Irma.
Yeah. Someone just asking, is there a reason to put off some routine stuff like that colonoscopy you mentioned until Medicare kicks in 2 months?
If you have your doctor, you have your doctor and they're taking you as an active patient, yes, because you're going to hit the $257 deductible, and then you have 100% coverage for those procedures, whether they're routine, diagnostic, as long as they're medically qualified. On the flip side, if you've already satisfied your plan, group plan or ACA plans, deductible and maximum for the year, then I would say do either. You're pretty limited in exposure at that point under the group or the Medicare pathway. But if you haven't met your group or your current plan's deductible or out-of-pocket max, then delay, because you'll pay way less under Medicare if you're going supplement and drug coverage. Medications, as you make this transition over to Medicare, it's nice to just get like a 90-day supply. So this transition into Medicare, like day one, you're not like, I need drugs and I signed up 2 weeks ago and I haven't got my Medicare card. And doing this sooner rather than later, especially given like the government's just turbulence. Start these processes early. Sometimes I've seen Medicare process a Part B application in 2 days. I've seen it take like 6 or 7 months because the rep just fumbles through the application and screws it up, or there's, I need a passport because there's a lot of things that can go wrong. So starting it sooner, and we check in with you every like 2 weeks to make sure everything gets coordinated at the right time.
Thank you. Okay,
so under this Drug Inflation Reduction Act, this is really nice. My Plan J out there, you know about this, but that donut hole that used to exist in Medicare, I used to have this slide that had a donut on it, no longer is there. any drug that you fill under your plan's benefit. So the key here is make sure your drugs are on the formulary every year, because as long as you're using your drug plan to fill that medication, and the pharmacist runs it through the drug coverage and it's on the formulary, it will go to that $2,000 bucket. So you fill Ozempic, you fill lisinopril at $2, you fill Eliquis at $600, and your cost is only like 40 or 50 bucks. Depending on how much you are paying in out-of-pocket costs, it all goes to that $2,000 bucket. Once you meet the $2,000 bucket, it's full. Now your drug plan pays all of your formulary covered medicines for the rest of the year. Okay, so there is no like 5% donut hole exposure anymore, which was crazy. Next year it's going to be 2,100, which is still very low. That's a win in my eyes. I thought it would be like 25, 2,600. So all of these plans reset January 1st, and this October through December is the sweet spot to start the enrollment process. If you guys want us to review your supplement, see if there's any, $1,200, $1,500 worth of savings there, we can do that now. You don't have to wait until October. We can do it year round. And then the drug coverage, reach out to me. I'll send you our intake form. We'll get you on our drug review list. It's pretty simple. It's just a lot of going through our software to see what's the best plan for you. Shoot me an email and I'll loop in my scheduling team who can send over those intake forms and get you processed and started, so we can reach out in October with a recommendation. But here, the key, again, is finding the drug plan that keeps your drugs on the formulary. And the drug plans are sneaky. They'll send you that annual notice of change, and your first, you open the document and you gasp because your rate just went up 50%. And you're like, I'm paying $100 now. And what's sneaky is they don't tell you they just took your Eliquis from a tier, excuse me, a tier 3 to a tier 4, exposing you to a lot more cost to get to that $2,000 cap. Sorry. So again, always review this coverage. It's critical. If you are delaying Medicare to stay on that large group plan, we need to make sure your plan every year remains creditable, which means the drug benefit that's baked into your group high deductible or just large employer plan, you need to make sure the drug plan is also meeting that $2,000 cap or the new plan design under Medicare. And if they are not changing their design, it becomes uncreditable, meaning it loses that status, and now you have to pick up a drug plan to avoid delays and gaps. And this is where the real planning starts. If with a lot of these group plans, if you're forced to get a drug plan because your group plan becomes uncreditable and you sign up for a standalone drug plan, with many of the group plans, the drug benefit is integrated with the medical. So as soon as you sign up for alternative standalone drug to avoid a penalty, it kicks you out of the medical benefit. So we want to avoid that. So some strategy is required here. So if you get a letter, what to take away from this slide? If you get a letter anytime throughout the year, usually it will come around your plan, your employer's open enrollment period. If you get a letter saying your plan's no longer creditable, you need to do something, just email me and we'll help you walk through kind of if, what, and when steps. And look at many factors, not just pricing. So, and then IRMA, sorry, I'm over my time, but I have time. So IRMA, this is where a lot of you will just be shocked at what Medicare actually will cost you. So Medicare, if you're moving into Medicare, you're enrolling in Medicare for the first time in 2025, or you're already on Medicare, it's been years you've been on Medicare. Every year, Medicare is using your tax return from the prior 2-year return. So in 25, Medicare is looking at your 2023 tax return, and they're grabbing the modified AGI figure from that 2023 tax return to set your 2025 Medicare and IRMA, the income surcharge premium. Okay, In 2026, everybody will automatically get shifted and notified of their new IRMA requirement and responsibility based on that 2024 tax return. 2027 will be on 2025. That movement happens automatically. You don't have to tell Medicare anything. But what Medicare doesn't know is if you have a life event, you retired in 2024, you retired in 2025, you stopped working because you got a divorce from a high earning spouse, or unfortunately there was a death of a high earning spouse. As soon as you have this life event and your income in the current year in 2025 is going to be far less than what you made 2 years ago on that modified AGI and tax return, we can tell Medicare, hey, here's proof of my life event. Here's my divorce decree. Here's a letter from my employer. Here's, a death certificate. My anticipated modified AGI for 2025 is going to be far less because of this life event. I only need to show proof of life event, not proof of income. And because of that, I'm requesting you use my 2025 anticipated modified AGI instead of that 2-year look back. Because I stopped working, I retired, my income's no longer high. I can't afford $1,000 in IRMA and supplement and drug because I'm not making 800 grand like I was in 2023. I'm now making 212 or 206,000. Okay, so now remove all my IRMA or reduce my IRMA based on my new anticipated income. And we don't need to show proof of income. We just need to show proof of the life event. So here, if you were making above 750,000 as a joint filer in 23, Medicare for each of you, just to get in the door for each of you, will be $715 plus your supplement, plus your standalone drug plan actual premium, plus dental. So that's where I get roughly $1,000 a month if you're in the highest IRMA bracket. And if you say, hey, Social Security, I'm not making that anymore. I'm now in the 266 to 334,000 joint bracket. Reduce my IRMA from 715 a person to 405 a person. And like the planning here, it's kind of a pain, but typically you'll have to do this twice. You'll appeal this year for 2025 to say, hey, I retired in 2025. Don't use 23, use 25. And then in December, you're going to get an IRMA notice saying, hey, in 26, we're using 24's income. And then it still doesn't show that retirement passive income. So we have to appeal again and say, oh, here's my life event. So usually 2 back-to-back appeals is required before Medicare is actually caught up with that retirement. And we walk clients through this all the time. I would say at least 50-60% of my clients, IRMA planning is part of the conversation, if not even more. So don't be alarmed. A lot of times we can appeal it, but also be aware if you're turning 65, you're working with a large employer. Again, Medicare may not be right because it's super expensive compared to your high deductible HSA qualified family plan. Once we are on Medicare, again, this fall is crazy busy for us. I have tape on my eyes for 7 or 8 weeks. My husband hates me. I'm just caffeinated. It's like the CPAs. So I respect CPAs, but they get all year. They can extend tax returns, right? Like I just had my deadline last week. Or a few days ago, Monday. So here, the fall is very busy. It's when we can really, for most of you, review the drug coverage. If you go Advantage, we can also make a shift on the Advantage coverage. The open enrollment, if there's an oopsie, oops, I got enrolled by some shady broker who told me my Medicare Advantage plan was everything I wanted, and it turns out it isn't, and you went from, Kaiser HMO to UHC HMO, and you can't use Kaiser doctors now. You can have a one-time kind of oopsie January through March to make a change to your Advantage plan. Or if you went supplement over to Advantage, you can drop the Advantage and go back to the supplement if it was your first time making that oopsie. Medicare supplement plans, again, most states are requiring underwriting. I want to say there's about 18 or 20 states, California, Virginia, Maryland are all included. DC is not, that allow for like seamless movement here on your birthday. But again, I don't think the goal here is to get the cheapest coverage every year, because now you're just in this game of like updating drug cards with your doctors and you know, getting pre-authorization on your Eliquis. Yet again, it can be frustrating to do that. So we're kind of looking at the whole picture, knowing that many of you don't want to have to get all new everything every single year to save $120. It's not worth the headache of updating all of your carrier, all of your providers in your pharmacy and resetting everything. So we take that into the equation when we do these drug reviews to just see where you are, what kind of savings we can have with your drug plan, your supplement, without impacting your access to care and losing medications on the formulary. ACA, sorry about that, got a slippery scroller here. Potential ACA changes. Again, we're kind of working real time here. Right now, if any of you got really creative with your modified AGI over the last 4 or 5 years, you were an early retiree, now you're looking at Medicare, awesome, you kind of got to work the system. But this Biden regulation with the enhanced subsidy access is set to expire at the end of January. So I'll use kind of real numbers here. So if you are a family of 2, a household of 2, right now making $85,000 in modified AGI and you're age 60, right now in 2025, you are getting subsidy through the marketplace, the California exchange, the Virginia exchange, or the healthcare.gov, the federal exchange. You have access to subsidy even though you're over 400% of the poverty line, which for a family of 2 is like 84,600 for next year. Next year, this subsidy cliff is coming back, and instead of having kind of a sliding slope, so anybody who's making a modified AGI above that 400% poverty line, right now under Biden law and regulation, it's a sliding slope. You know, you get a little discount, but it's not all, you're not forced to pay the full premium, $2,000 premium. In 2026, if these enhanced subsidies expire, as soon as you go over that 400% benchmark, which is 84,600 for a family of 2. So if you plan to make the same 85 grand in 2026, you no longer get that sliding slope subsidy access. It's a fall off, it's a cliff. So instead of getting, you know, 1,100, 1,200 in subsidy allowance or 600 in subsidy allowance every month off your full premium, you now are paying the full premium, which for like a silver plan for a family of 2 is about 1,800, 1,900 a month. So that's one thing is set to happen unless there's this wild card bill that's approved, okay? So you probably can't play the game unless you really can modify your AGI and keep it under that 400% poverty level. That's going to be the key. For anyone who couldn't get slick with their modified AGI, didn't have the cash flow, you are naturally going to see about an 18% national average increase on all plans across the ACA, because these carriers are looking at this enhanced subsidy expiring and they're scrambling. They're saying, we got to price our plans accordingly, knowing that this regulation is really going to hurt us. We're not going to get the enrollments. We're not going to get the kickbacks from the government to enroll people. So not only are people going to see a sticker shock if they're on the 406% line on the poverty, they are also going to see sticker shock just naturally with this 18% on average rate increase across the board, whether or not you get the subsidy. So that's something that's happening. If you have Aetna is exiting all ACA under 65 markets. So you're safe if you have a group plan, but if you're on a state exchange plan, on or off exchange, and you have Aetna, it's going away. And in some markets, Aetna had the robust network. So this is a huge disruption to a lot of hospital systems. Again, I'm from Missouri. Missouri, Aetna is the only plan that has the big Barnes Jewish Hospital Network, which is like the teaching school, the big St. Louis hospital, and it's going away. And none of the other 4 or 5 carriers have stepped up to say, we'll take BJC, because they are super expensive with their requirements. So again, Aetna is going, you'll have to make a change there. This is positive. ACA, all of the bronze plans are going to be HSA qualified. So again, if you don't have a lot of chronic care needs, I'd look at the bronze plans to avoid that huge premium increase if you are losing subsidy access or you're getting hit with the 18% average increase. The bronze plans can keep your costs low, and now you can also receive the tax benefits of being able to contribute, close to 10 grand into an HSA account if you have a family ACA bronze plan. So there is some benefit to going bronze this year than we've seen in the past, because in the past, the HSA plans, it was like 1 or 2 HSA allowed plans in each market. It was crazy. So this is a cool perk to the big, beautiful bill. Maybe the only perk in my eyes, but okay. That's a different discussion. I'll loop in Yesky Buey for that one. So I think the takeaway from this entire webinar is start planning sooner rather than later. There's a lot of changes, a lot of planning, a lot of strategy that we can bring in. There's no one size fits all approach. Start it sooner rather than later. I'm going to pull up my email here, my phone number. Shoot me an email anytime. Bring in Lauren, the whole team there. It's fun to work with you all. We love what we do. We're very passionate about it. And thank you for showing up. So yeah.
Thank you. Thank you so much, Margot. Yeah, if you make sure you note down Margot's contact information here. If you don't get it, I'm happy to share it with you personally. If you had questions that you didn't type up or you think about after the fact, please email us, email Margot directly. If you have personal specifics you want to ask her about for your plan, or you're ready to get started on your planning and get things moving early, reach out to her. And with that, I will say thank you all for being here with us today. Hope you all have a wonderful rest of your afternoon and week, and take care.